Welcome to the Indiana Department of Labor webinar on the OSHA COVID-19 Emergency Temporary Standard for Healthcare. I'm Gary Halbert, and I'll be presenting the material with Brad Freeman. We intend to cover the scope of 29 CFR 1910 Subpart U, the requirements for healthcare, the Mini Respiratory Protection Program, and the incorporations by reference. OSHA determined that there was a need for an emergency temporary standard due to the fact that employees in healthcare and support employees face a grave danger from COVID-19. Subpart U contains the following temporary standards. 1910-502 covers healthcare. 1910-504 covers the Mini Respiratory Protection Program. 1910-505 is severability. 1910-509 are incorporations by reference of CDC and consensus standard guidelines. The emergency temporary standard effective dates for federal OSHA was effective immediately upon publication in the Federal Register on June 21st, 2021. Most provisions were effective on July 6, 2021. Training, ventilation, and barrier provisions by July 21st, 2021. Indiana had 30 additional days to comply because we're a state plan state. 1910-502A covers the scope and application. The standard applies to healthcare work sites where any employee provides healthcare services or healthcare support services. These include hospitals, nursing homes, and long-term healthcare facilities, healthcare settings embedded in a non-healthcare setting, such as medical clinics in a manufacturing facility and walk-in clinics in a retail setting, and autopsy settings in funeral homes are covered, but they are not covered other handlings of human remains. Where EMTs or other healthcare providers enter a non-healthcare setting to provide healthcare services, only the provisions of the healthcare services by that employee is covered. Definitions, according to federal OSHA, are healthcare means services that are provided to individuals by professional healthcare practitioners. Examples are doctors, nurses, emergency medical personnel, and oral health professionals for the purpose of promoting, maintaining, monitoring, or restoring health. Healthcare services are delivered through various means, including hospitalization, long-term care, ambulatory care, home health and hospice care, emergency medical response, and patient transport. Healthcare support services means services that facilitate the provision of healthcare services. Healthcare support services include patient intake and admissions, patient food services, equipment and facility maintenance, housekeeping services, healthcare laundry services, medical waste handling services, and medical equipment cleaning and reprocessing services. Ambulatory care means healthcare services performed on an outpatient basis without admission to a hospital or other facility. It is provided in settings such as offices of physicians and other healthcare professionals, hospital outpatient departments, ambulatory surgical centers, specialty clinics or centers such as dialysis, infusion, and medical imaging, and urgent care clinics. Ambulatory care does not include home health care settings for the purposes of this section. Well-defined areas mean a portion of the facility that could be an entire department, such as a radiology unit, or a section of a building, such as a room, floor, or wing. Break rooms and lunch rooms are included in well-defined areas. 502A healthcare does not apply to first aid performed by an employee who is not a licensed healthcare provider, dispensing of prescriptions by pharmacists in retail settings, Non-hospital ambulatory care settings, if non-employees are screened and COVID positive and suspected people are not allowed entry. Hospital ambulatory care settings, if well-defined areas, all workers fully vaccinated, non-employees are screened, and COVID positive and suspected people are not allowed entry. Home health care settings, if all employees are fully vaccinated and non-employees are screened. Offsite healthcare support services, telehealth services outside of direct patient care settings. There is a partial exemption in 1910-502 in well-defined areas where there is no reasonable expectation that any person with suspected or confirmed COVID-19 will be present. Paragraphs F, personal protective equipment, H, physical distancing, and I, physical barriers, do not apply to employees who are fully vaccinated. Examples of applicability of 1910-502. An example using a clinic and a manufacturing facility. 1910-502 applies to the nurse's duties, whether in the clinic or out on the plant floor. However, it does not apply to other employees in the manufacturing facility when the nurse is providing health care on the plant floor. Examples used in a pharmacy embedded in a general merchandise store. 502 applies to the pharmacist and staff performing medical processes and procedures such as administering vaccines, but it does not apply to dispensing of prescriptions or to the general merchandise part of the store. 1910-502 requirements. The company is required to develop and implement a COVID-19 plan, patient screening and management, standard and transmission-based precautions, personal protective equipment, aerosol-generating procedures on a person with suspected or confirmed COVID-19, physical distancing and physical barriers, cleaning and disinfection, ventilation, health screening and medical management, vaccination, training, anti-retaliation, implementation at no cost to employees, record keeping, reporting COVID-19 fatalities and hospitalizations to OSHA. And we're going to go into each one of these a little bit in the next few slides. The 1910.502C pertains to the COVID-19 plan. A plan must be developed and implemented for each workplace. It has to be in writing if there's greater than 10 employees. Documented, designated safety coordinator that will implement and monitor the plan must be included. Conduct a workplace-specific hazard assessment, and if the hazard assessment is based on the employee's fully vaccinated status, the plan must include procedures to determine employees' vaccination status. The COVID-19 safety coordinator should be someone who is able to understand and identify COVID-19 hazards in the workplace and must be knowledgeable in infection control principles and practices as they apply to the workplace and employee job operations. Additionally, the safety coordinator must have the authority to ensure compliance with all aspects of the COVID-19 plan and take prompt corrective measures when hazards are identified. Employers must seek the input of non-management employees and their representatives, monitor ongoing effectiveness and update the plan as needed, develop procedures to address the hazards identified which minimize the risk of transmission, effectively communicate and coordinate with other employers, and protect employees who in the course of their employment enter into private residence or other physical locations controlled by a person not covered by the Occupational Safety and Health Act. 1910-502D covers patient screening and management. In settings where direct patient care is provided, the employer must limit and monitor points of entry, screen and triage all entrants as necessary, Implement other applicable patient management strategies in accordance with CDC's COVID-19 infection prevention and control recommendations. Examples of these include telehealth, where applicable, isolate patients in exam rooms, and use distancing and barriers in waiting rooms. 1910-502E is standard and transmission-based precautions. Employers must adhere to standard and transmission-based precautions in accordance with CDC's guidelines for isolation precautions. Examples of these include tight-fitting face masks for patients, physical distancing, hand hygiene, ventilation, outdoor triage, and isolation rooms. 1910-502F is personal protective equipment. Face masks must be FDA approved or authorized. Face coverings are no longer authorized. Employers must provide sufficient number and enforce use. They must cover the nose and mouth when indoors and when occupying a vehicle with other employees from work, and provide a sufficient number to allow at least one change of the mask per day and whenever they're soiled or damaged, and more frequently as needed. Use of respirators when not required must comply with 1910.504, the mini respiratory protection standard.
2, 1.
1910-502F is personal protective equipment, which covers respirators and other personal protective equipment for exposure to people with suspected or confirmed COVID-19. Respirators must be provided and used in accordance with 1910.134 Respiratory Protection Standard, which includes annual fit tests, medical evaluations, and employee training. Gloves, an isolation gown, or protective clothing and eye protection must be provided and used in accordance with 1910 subpart I, which is personal protective equipment. Note to paragraph F2, where there are limited supplies of filtering facepiece respirators, employers may follow the CDC strategies for optimizing the supply of N95 respirators. 1910-502F and G covers aerosol-generating procedures on a person with suspected or confirmed COVID-19. Respirators must be provided and used in accordance with 1910.134, gloves, an isolation gown, or protective clothing, and eye protection must be provided and used in accordance with subpart I. Limit the number of employees present during the procedure to only those essential for patient care and procedure support. Perform the procedure in an aerosol infection isolation room if there's one available. And after the procedure is completed, must clean and disinfect the surface and equipment. 1910-502H covers physical distancing. Each employee is separated from all other people by at least 6 feet when indoors. If it's not feasible for a specific activity such as hands-on medical care, the employer must ensure that the employee is as far apart from all other people as is feasible. This does not apply to momentary exposure, such as when people are passing each other in the hallway. 1910-502I covers physical barriers. At each fixed work location outside of direct patient care areas where 6 feet of distance is not feasible, the employer must install cleanable or disposable solid barriers. Barriers must be sized and located to block face-to-face pathways between individuals, and barriers may have a pass-through space at the bottom for paperwork materials such as that. 1910-502J is cleaning and disinfection. In patient care areas, resident rooms, and for medical devices and equipment, must follow standard practices for cleaning and disinfection in accordance with CDC's COVID-19 infection prevention and control recommendations and CDC's guidelines for environmental infection controls. Examples include dedicated medical equipment for infected patients and using pathogen-appropriate EPA registered disinfectants. In all other areas, the employer must clean high-touch surfaces such as door handles and countertops and equipment at least once a day. When the employer is aware that a person who is COVID-19 positive has been in the workplace within the last 24 hours, must be cleaned and disinfected in accordance with CDC's cleaning and disinfecting guidance. Any area, material, or equipment under the employer's control that have likely been contaminated by the person who is COVID-19 positive. The employer must provide alcohol-based hand rub that is at least 60% alcohol or provide readily accessible hand washing facilities. 1910-502K is ventilation. Employer-owned or controlled buildings with existing HVAC systems must follow manufacturer's instructions and specifications, maximize outside air and air changes per hour as appropriate, use air filters with minimum efficiency reporting values equal to or greater than 13 if compatible with the system, replace filters as necessary, and the intake ports must be cleaned, maintained, and cleared of debris. Airborne infection control rooms must be maintained and operated in accordance with design and construction criteria. CDC also has ventilation guidelines that the employers may follow as well. Now, Brad Freeman is going to continue with the slides.
Okay. Thank you, Gary. I am Brad Freeman, and I'm going to continue with 1910-502, paragraph L, which is health screening and medical management. And screening refers to asking employees questions about COVID-19 symptoms or taking their temperatures, although taking their temperatures is not required. Now, screening can be in person, or the employer can ask employees to self-monitor. If an employee is confirmed, has a confirmed diagnosis, they do have to immediately notify the employer, or if they're a suspected diagnosis and they're told by a healthcare professional they may be in the process of being tested, but they don't have that confirmed clinical diagnosis, or they have a recent loss of taste or smell or a fever of 100.4 and new explained cough with shortness of breath, they would have to inform their employer immediately. Okay, moving on in paragraph L, the employer may have, the host employer may have contractors on site. They may have temporary staffing agency employees on site, and OSHA would expect the host employer to notify the employers of those employees if that employee was exposed or is in close contact with someone positive for COVID-19 during that potential transmission time. And that way that employee can get tested or have a medical removal from work. Okay, now medical removal from work, that would apply to persons meeting positive test diagnosis criteria. They should immediately be removed until they meet the return to work criteria, which we'll go over. Persons meeting the suspected diagnosis symptoms should be immediately removed from work until they meet the return to work criteria or have a negative PCR test. Persons with close contact must be removed immediately, either for 14 days or until they have a negative PCR test taken after at least 5 days, and then after 7 days they can come back. There is an exception to that if the person is asymptomatic and has fully vaccinated or recovered from COVID-19 in the past 3 months. Also, there is alternatives to medical removal if the employee can work remotely or maybe be isolated so they can't transmit COVID-19. Okay, medical removal protection benefits. OSHA does feel that these benefits are necessary so employees are more comfortable reporting when they have symptoms or have COVID-19 positive test, and so they won't jeopardize other people's health in the workplace. Now, employers with less than 10 employees are exempt from removal pay. but employers with more than 10 employees would have to pay their employees their regular pay and benefits up to $1,400 per week. And of course, if they're working remotely or in isolation, they would be entitled to the same pay and benefits. If the employee is receiving some type of workers' compensation benefit, then the employer would just have to make up the difference. And also, the American Rescue Plan does have tax credits to offset some of these costs of sick leave or medical removal that's required. Okay, and when the employee does return to work, they should be returned to the same job status, rights, and benefits. Okay, the return to work criteria, this is something that we have adopted in our consensus standards incorporated by reference, and we use the CDC's return to work healthcare guidance for that. We also encourage employers to listen to any licensed healthcare providers because some employees may deviate from the normal return to work criteria. For example, they may have a more serious illness. They may be immunocompromised and require a longer to be longer off work. Okay, vaccinations. OSHA believes that vaccinations is a vital tool in reducing the presence and severity of COVID-19 cases. And although it's an individual's decision to receive or not receive a COVID-19 vaccination, barriers should be removed. So employees do have time if they choose to have the vaccination. So employers should allow employees and pay the employees for time to get the vaccination and for any side effects experienced following the vaccination. Okay, training. So subpart N, over the next couple slides, we're going to talk about training. And this is vital also, so employees know what to do under the employer's COVID-19 plan. So when the employer does implement the plan, it's effective and it will reduce the likelihood that workers will spread COVID-19. Employers have a lot of flexibility for conducting this training. They can choose in-person training, web-based training. They can distribute educational materials, but there should be some type of interactive period where employees can ask questions. So some of the content that employers should go over would be COVID-19 transmission, hygiene, ways to reduce or spread signs and symptoms of COVID-19, risk factors of severe illness, when to seek medical attention, employer-specific policies and procedures on patient screening and management, workplace tasks and situations that could result in infection, workplace policies and procedures for preventing spread, and multi-employer agreements related to infection control policies and procedures. Okay, also policies and procedures for PPE, workplace policies and procedures for health screening and medical management, sick leave policies, the identity of the safety coordinators specified in the plan, and details of the standard and how the employee can obtain copies. Now, OSHA expects employers will have implemented provisions that is similar to what's in the ETS. So in many cases, employers would just have to complete any new training on new items. Okay, there are other times employers have to do additional training. That would be changes in the workplace, or if an employee's job changes in policies or procedures, indications that the employee has not retained or understood the skill, training oversight or provisions by a person knowledgeable in the subject matter related to the employee's job duties, and again, opportunities for interactive question and answers. And also, the training should be done in the language and literacy level of the employees. Okay. Anti-retaliation and paragraph O includes provisions to ensure employees are aware of their rights under the standard and that they are protected from retaliation for exercising those rights. So Employers cannot discharge or discriminate against an employee for exercising those rights under the standard. Okay, 1910-502, paragraph P. This is requirements implemented at no cost to employees. So this provision is included to make it clear that the employer is responsible for costs associated with the implementation of the standard. And this requirement is consistent with the OSHA Act. Now, one of the exceptions would be if you have an employee that's self-monitoring at home for a couple of minutes. We wouldn't expect the employer to pay the employee for checking their temperature at home. Okay, record keeping. Employees that have less than 10 employees would be exempt from record keeping, and this is in keeping with OSHA's general record keeping requirement now. Okay, employers with more than 10 employees are required to establish and maintain a COVID-19 log and record each instance identified by the employer in which an employee is COVID-19 positive, meaning that person has a confirmed positive test. Okay. Now, there are certain things that have to be on the log. That would be the employee's name, contact information, occupation, location of work, date of last day at workplace, date of positive test or diagnosis, first date of symptoms, if any. And this should be recorded within 24 hours of the employer's learning that the employee is COVID-19 positive. And one thing to keep in mind is this is the entry should be made on the log whether it is work-related or not. OSHA feels that it's more urgent to record an instance where an employee is COVID-19 positive and the details surrounding that instance than to wait to determine whether it is work-related. And also entering this information on the COVID-19 log about an employee with non-work-related illness can assist the employer in tracking how and when the disease entered the workplace. Okay, record keeping. The record keeping should be made available by the end of the next business day after a request, and that could be made by a variety of people under different circumstances. For example, the COVID-19 plan should be made available to employees or personal representatives of that employee. If the individual was tested positive for COVID-19 is on the log, they can request the log, but that would just be for that employee or anyone having a written authorized consent for that employee. Now, anyone can actually request the log, but a redacted version of that log with personal identifying information would have to be removed. And of course, all records should be made available to the Assistant Secretary of the Department of Labor. Okay, reporting COVID-19 fatalities and hospitalizations. Any work-related COVID-19 fatalities should be reported within 8 hours of learning of the fatality. Work-related inpatient hospitalizations should be reported within 24 hours of learning of the hospitalization. And the key there is learning. It's not actually when it happened. I know there could be some lag time, but it's when the employer learns of it. Okay, the mini respiratory program. This program here only applies when a respirator is not required. If a respirator is required, then the 1910.134 standard for respiratory protection would be used. Okay, so this is only voluntary use. This is where somebody may be wearing a face mask and would feel more comfortable wearing a respirator. And there's two scenarios. There's one where the employee brings in their own respirator, maybe an N95, or the employer provides that respirator. Okay, so 1910.502 F2, if you have an exposure with an expected confirmed COVID-19 case, then the 1910.134 applies. That's the general respiratory protection standard. Okay, 1910.502 F3 for any aerosol-generating procedures with suspected confirmed COVID-19, 1910.134 would apply. 1910-502F5 for standard and transmission-based precautions. The 1910.134 would apply. Again, the only time it wouldn't apply, as you can see, is 1910-502F4 in place of a face mask when a respirator is not required. Okay, the main differences, there are three main differences with the mini respiratory program. There are no medical evaluations are needed, no fit tests are needed, and no written program is required. However, the employer would be required to do some things. For example, they would have to do some basic training. They would have to provide workers with a notice in 1910.504C, which informs the employee that they should take precautions to be sure the respirator itself does not present a hazard. So the employee should read all the instructions provided by the manufacturer of the respirator on use, maintenance, cleaning, storage, and have procedures in place so they don't mistakenly wear someone else's respirator. That's if the employee does not, if they provide their own respirator. If the employer provides the respirator, they have to do a little bit more training. They have to show the employee how to inspect, put on, remove, and use the respirator. They have to go over the limitations and capabilities of the respirator, how to store, maintain, inspect a respirator, how to conduct a user seal check, and how to recognize medical signs and symptoms, and what to do if they do. Breathing through some of these respirators, because there is a filter on it, can cause some distress. It does take a little bit more effort to breathe through these. Training must be appropriate in the language and literacy level before the first use of the respirator, and still checks before each use, and again, reuse properly. And the CDC has some guidelines on reuse of respirators. So 1910-509, that's incorporated by reference, and the CDC has some guidance on return to work policies, some isolation guidance, and the EPA has some guidance over cleaning and disinfection, and that can be found in 509. This is in place. This is where OSHA may not have a standard. Now, OSHA can enforce one of these they could use a CDC guideline, and they can cite the general duty clause and reference that CDC or EPA guideline. And here are some links that would be good for the employer. There's a COVID-19 plan template, COVID-19 healthcare worksite checklist, and employee job hazard analysis, sample COVID-19 log, reporting COVID-19 fatalities and inpatient hospitalizations to OSHA, employer notification tool. There's a communication guide that can help coordinate between employers. There's a sample employee COVID-19 health screening questionnaire, and there's employee training presentation as well. All of this can be found on the OSHA website. Okay, if you do have any questions, you can contact InSafe. We are free. Our contact information is on this slide, and we will do our best to answer any questions you might have over the emergency temporary standards, or if you have any other safety or health questions.